Louis. It's nice to see this room still full of people. I'm going to talk for these 20 minutes about a quite advanced system for cerebral monitoring. So we go from €6 to something a bit more expensive.
2,000. Yes, it's 2,000 euros.
The technology by itself, I tried to make this presentation in terms of clinical or potential clinical utility, and if we have some time, I'm going to talk about some interesting data in terms of translational research. The technology, the cerebral microdialysis, consists in the insertion in the brain parenchyma of a specialized catheter tipped with a semi-permeable dialysis membrane. So the principle is the same as a dialysis system where the catheter is perfused at a slow and constant rate using a syringe containing isotonic fluid, usually is an artificial cerebrospinal fluid solution, via a pump system. And so this fluid equilibrates in brain interstitial tissue, and it allows recovery into small vials. It's about not more than 50 microliters, usually every 60 minutes, at least with cerebral microdialysis system that can be used at the bedside. And so you have patient brain extracellular fluid. And this fluid is analyzed at the bedside for the concentration of patient neurochemistry using a kinetic enzymatic methodology. And so you can assess online regional patient cerebral metabolism. And it's important to stress the fact that it's a regional measurement. So this is the illustration of this technique with the cerebral microdialysis catheter, this syringe pump system, and in here you have the collection after 60 minutes of patient extracellular fluid that you can then analyze using this small system. And here you see a picture of this system in our ICU in Lausanne. And you can even have it on top of a small refrigerator so that you can keep some liquid apart. And again, this system can be combined with other intraparenchymal probes. And so, again, this slide for the rationale for the use of microdialysis, where with these microdialysis probes and this dialytic system, you can assess the metabolites and brain extracellular fluid so that you can assess the function of the so-called gliovascular unit and how energy flow is regulated. And we have seen this morning the interplay between glucose metabolism, neurometabolic coupling, neuronal activity, neurovascular coupling, and so it's a system which theoretically is possible, with which theoretically is possible to analyze the function of this system. And you can define, if we go now more into clinical practice, the two main brain energy metabolic patterns, as I've shown you this morning: aerobic metabolism, where the excess of glucose can be converted into lactate that can be used by neurons, and the glutamate production to glutamine. So you can assess glucose, pyruvate, lactate, and glutamate at the bedside, not glutamine on regular analyzers. Whereas if you have elevated lactate and low pyruvate, which you will have then elevated lactate to pyruvate ratio, this is a marker of cell dysfunction, hypoxia, metabolic failure. What about the clinical utility of cerebral microdialysis? So this is what you find in the normal human brain. And again, this is the perfusion rate at 0.3 microliters per minute, which is what we use normally, at least in our institution and in many other institutions. And what you see here is that you have higher concentrations of lactate in the extracellular fluid. What you can then calculate is the lactate to pyruvate ratio. And the lactate to pyruvate ratio is probably what has been mostly studied in terms of clinical investigation to assess the cell redox. And about thresholds, it's important to see this tool, as we have talked about brain tissue oxygen, of also the dynamic changes over time. And if you have an ischemia or a hypoxia pattern, you have reduced brain glucose, elevated lactate. If it's hypoxia and anaerobic metabolism, low pyruvate, and therefore the lactate to pyruvate ratio goes up. And again, the LP ratio has been extensively studied. And if we talk about thresholds, we consider elevated lactate as above 4 millimole per liter. We consider low glucose or neuroglycopenia as below 0.7 or below 1, depending on the studies. And there is no doubt that the lactate to pyruvate ratio above 40 is considered as a marker of cell energy dysfunction and ischemia hypoxia. I think it's important to stress the point that the catheter location is very important. It's in subcortical white matter, as you see here in one of the patients at our institution, and you can insert it in normal appearing tissue versus around a contusion or an hematoma if it's TBI, or in so-called areas at risk for secondary delayed cerebral ischemia if it's subarachnoid hemorrhage patients. And the majority of the studies conducted in terms of clinical investigation is in TBI and SIH patients. You can use a triple or multiple lumen bolt. This system you see here, and so you can add microdialysis to ICP and PbTO2. And this is inside the parenchyma. So if you want to then drain fluid, CSF drainage, you have to add an intraventricular catheter. But that's what we use in our patients, both TBI and SIH. But I think it's important, if you add the cerebral microdialysis catheters, depending on the question you ask, you can read this paper by a Spanish group, it's POCA, and I think it's Sauquillo, about the percutaneous tunneling, and so that you can really place the catheter in the area where you want. The disadvantage of the system is that the catheter is less well fixed, but still, this paper is an important one in terms of technology. Now, if we come to clinical utility, the first, I would say, area of clinical investigation is about ischemia monitoring. So can we add this tool to see what is happening in terms of cell energy flow and function? And there has been few studies in the beginning of 2000, and this is one illustrative study from the group in Berlin, Sarafzadeh, Unterberg. They've done a lot of studies in patients with poor grade SIH. So these patients are at higher risk to undergo cerebral ischemia. And what they analyzed is the dynamic changes of the two main metabolic patterns, the lactate to pyruvate ratio and the glutamate. And so that you can discriminate between groups of patients, the typical clinical course of an asymptomatic patients, where the first increase in glutamate because of increased neuronal activity goes down and the LP ratio stays stable. The second typical clinical case is a ischemia with reversible symptoms, where you see that the lactate pyruvate goes up and then it goes down again. Whilst if you have further clinical deterioration and somehow irreversible deficits, this lactate to pyruvate ratio and glutamate goes back up again, And then if everything is failed, these two markers stay up. So this is a way to follow the dynamic changes. And some studies have shown that these dynamic changes precede what is going on in terms of standard brain physiological variables, like for example ICP. You can target, therefore, one of the main medical therapy used for SAH patients, which means induced hypertension and hemodynamic augmentation, and you can combine, as this recent study performed at Columbia University, you can use the combination of microdialysis and brain oxygen to target CPP in these patients. Whilst if we talk about TBI, we have seen that there is a lot going on which is not ischemic. And this is a demonstration where actually you can target CPP thresholds towards lower between 50 and 60 millimeter per mercury without affecting energy flow and function. And so that this is a demonstration again that we don't need necessarily to maintain elevated CPP levels in the population of patients with brain trauma. And you can also use the combination of the two, brain oxygen and microdialysis, to assess not only CPP thresholds, but thresholds of hemoglobin. And when you have a patient at risk for ischemia and anemic, and you see a trend of lactate to pyruvate ratio going up and concomitantly PbO2 going down, maybe, even if it's probably not evidence-based medicine, but rather medicine evidence, medicine-based evidence, sorry, you can maybe transfuse these patients. And again, we have talked about vasoreactivity, but also CO2 reactivity, and this paper is a demonstration where if you reduce PCO2 and you hyperventilate too much your patients, you can see some patterns of energy dysfunction. So you can use this tool in addition to the other tools we have described. And this is the SAH consensus, international experts published in Neurocritical Care. Some of these international experts are here, and they say that in sedated or poor grade SA patients, clinical deterioration may be difficult to assess, so that PbO2 monitoring and or cerebral microdialysis are options for monitoring of DCI and guide the treatment in terms of pathophysiology-oriented therapy. There has been quite a lot of studies using cerebral microdialysis to warn clinicians that with the introduction of insulin therapy in the ICU, the brain, of course, glucose is dependent on blood glucose, and so that you do not need to be too intensive or over-aggressive. And this is one of the studies showing that by using tight control, intensive therapy, you can actually harm and induce cerebral metabolic distress. So the moderate is probably, or intermediate, what we call, is probably preferred. And right now in neuro-intensive care patients, the targets of 7 to 10, which is 140 to 180 milligram per deciliter, is mainly used. And we know that because several groups have demonstrated that the low brain glucose may not be always well tolerated, and there is some association between low brain glucose as an indicator of energy failure and outcome. And we have also seen today that ischemia is not the only issue, and there are other issues in terms of cellular hypoxia. And we have talked about excitotoxicity, reduced cerebral glucose supply, cerebral glycolysis, mitochondrial dysfunction, and so on. And so to assess the cellular redox state may give you additional information at the bedside. And this again has been shown, we have, by studying cerebral microdialysis, at least increase our understanding about how things are going on in the brain injured patients. And I think that at least this tool has, to my personal view, increased somehow our knowledge of certain processes. And if we have talked today about certain things, there is definitely some knowledge coming out from cerebral microdialysis study. And again, lactate to pyruvate ratio may be elevated not only because of ischemia. So that this is important. I think this is also important to note that ICP and CPP alone you may skip a lot of things going on, and the sensitivity and specificity is very low. So that can be a lot of things going on in terms of what has been defined in this study as a cerebral compromise, and though the ICP and the CPP are in so-called normal ranges. And then if we talk about why this is useful, I think that this paper from the Cambridge group is the largest study using cerebral microdialysis markers. They included more than 200 patients, and again, these in this center they have really strict standardized protocols, and they have demonstrated that particularly elevated lactate to pyruvate ratio and low glucose are independent predictors of poor outcome, so that these can also be used in future studies to maybe as a physiological endpoint. And I would conclude this first part, and if I should have a few minutes just to show a few slides of translational research. The conclusion of this consensus was that microdialysis is the only tool that allows continuous measurement of tissue chemistry in the brain extracellular space. And so they seem to be in favor of adding this tool when you can in clinical management. And you can better understand certain forms, like for example the non-ischemic forms of brain tissue hypoxia. Then you can use high-resolution microdialysis to better assess brain pathophysiology. And in terms of implementation, it's not so easy. We have now worked on microdialysis for 18 months and is now going on pretty well, I would say. It costs quite a lot of money, but I think it can add additional knowledge, and it can be inserted in the increased development and use of the so-called brain multimodality monitoring, so that in comparison of CMD, cerebral microdialysis is almost ready for the prime time in terms of clinical utility and utilization. And it can be also interesting in terms of better understanding of pathophysiology. And if I have just 2 minutes for translational research, these are the potential applications, not only neuro-ICU, but also intraoperative measurement, epilepsy, drug pharmacodynamics, kinetics, and proteomics. These are all potential applications, and I will strongly recommend you, if you're interested in this topic, to read the review by Hillard, Vespa, and Hovda in the Journal of Neurotrauma 6 years ago. This is probably the most comprehensive review of cerebral microdialysis, how you can use it in clinical practice and also for translational research. And this is a very recent study from London, Martin Smith's group, where they use a catheter with a higher cutoff. So the normal clinical cutoff of the cerebral microdialysis catheters is 20 kilodalton, but you can use 100 kilodalton cutoff catheters, which can be inserted locally in particular areas of the brain. And with these catheters, you can collect and assess larger proteins. So that can be used for studying in more details the pathophysiology of brain injury, as it was the case in this study with neurofilaments in TBI patients. Or this other study I showed this morning from Brody, and also Nino was involved, where you can assess the early phenomenon, in this case amyloid beta deposition in patients with traumatic brain injury, and for example demonstrated that there is early axonal injury going on in these patients. And this is my last slides. You can even go for further studies in the future, and the study I've shown in the amyloid beta, they have demonstrated that the extracellular fluid gives additional information when you correlate it with neurological function of the patient than the intraventricular fluid. And so I think that this opens up new areas, hopefully, of potential clinical and translational research investigation. And with that, I land, and thank you very much.